Hi friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. In this video, I am going to discuss about ectopic pregnancy. Okay, so the definition of ectopic pregnancy is gestational sac outside the uterus. Okay, simply gestational sac outside the uterus. Okay, and the most common site of ectopic pregnancy, is fallopian tube, and in the tube most common location is ampulla of fallopian tube. Okay, moving on to the etiology of ectopic pregnancy. Okay, the most common cause is salpingitis, inflammation of fallopian tube. Okay, it is the most common cause, and other causes include previous ectopic pregnancy. Okay, tubal surgeries, and also in contraceptive failure. Okay, now let's move on to the fate of ectopic pregnancy. Okay, fate. The ectopic pregnancy either go for a rupture, okay, or it remain unruptured. Okay, so the clinical features will be different for rupture and unrupture. So let's discuss about the ruptured ectopic pregnancy first. Ruptured ectopic. Okay, so the clinical triad which is seen in 50% of cases of ruptured ectopic pregnancy are: first, there will be a period of amenorrhea, followed by abdominal pain, followed by bleeding PV. Okay, this is the clinical triad seen in most patients with the ruptured ectopic pregnancy. And the other clinical features include patient is in shock. So you have to manage the shock with the IV fluids, bloods, send blood investigations, and prepare for emergency laparotomy. That is the treatment of choice. Okay, so the other clinical findings include tense, tender, rigid, and guarding uterus. Okay, there is something called Cullen sign, that is periumbilical discoloration. Okay, and there is Gray Turner sign. It is not specific for ruptured ectopic. Okay, it is also seen in many other conditions. So there is a Gray Turner signs, that is bluish discoloration in flank. Okay, and on per vaginal examination, there will be cervical motion tenderness. Okay, it is an important feature. Okay, now moving on to the management part. Management of ruptured ectopic. It is nothing but immediate laparotomy. You have to open the abdomen, followed by salpingectomy. Okay, that is the treatment of ruptured ectopic. Now let's discuss about unruptured ectopic. Okay, unruptured ectopic. So the clinical features will be like patient may be either asymptomatic, there will be no symptoms. Okay, amenorrhea may be there. Sometimes there will be mild abdominal pain or vaginal bleeding. Okay. On examination, there will be lower abdominal tenderness may be present. Okay. And uterine size will be less than period of amenorrhea, because as the baby is ectopic, it may not grow. That's why uterine size will be less than expected. Okay. And the diagnosis is made by transvaginal sonography. Okay. On TVS, the finding will be empty uterus. On transvaginal ultrasound, there won't be any sac in uterus. Okay, empty uterus. And you can see gestational sac in other places like tubes. Okay, in tubes. And on Doppler scan, there is something called a classical sign for ectopic pregnancy, that is ring of fire appearance. Okay, that is if the sac is identified outside the uterus, that is in tube. But what if there is no sac in uterus and there is no sac identified outside the uterus? Okay, so pregnancy of unknown location, it is also included in unruptured part only. Okay, so the pregnancy of unknown location. Okay, that is on TVS, on transvaginal sonography, there will be empty uterus and also empty tubes. There is no sac in tube also. In such situation, do beta HCG. Okay, and if it is less than 1500 milli international unit per ml, then you have to do serial beta HCG monitoring in every 48 hours. Okay, so how to interpret the results of serial beta HCG monitoring? It is done according to Kedar and Romero principle. Okay, Kedar and Romero principle. Okay, you have to look for the rise in serial beta HCG. Okay, if rise in serial beta HCG is like this. If the rise is more than 66%, okay, the sac is not visible in TVS. Okay, so we don't know where the sac is located. So if the beta HCG is rising more than 66% of the previous value in every 48 hours, we are expecting the sac, or the sac might be in intrauterine. Okay, intrauterine, within the uterus only. So we are expecting a intrauterine pregnancy according to the principle of Kadar and Romero. Okay, intrauterine pregnancy. What if the beta HCG is increasing, but the increase in beta HCG is less than 66%? It may be ectopic pregnancy. And what if the beta HCG is falling? Okay, it is not rising, instead it is falling. Okay, then the pregnancy may be already aborted. Okay, the interpretation is abortion. Okay, so this is how you interpret a pregnancy unknown location, gestational sac with unknown location. Okay, now moving on to the management part of unruptured ectopic. Okay, you can go for either expectant management, that is just observation. Okay, or you can go for medical management, and or if not fitting to both, you can go for surgical management. So there are certain criteria which management have to be followed. So the criteria for expectant management, okay, expectant management is done if there is no fetal heart sound, or there is a falling beta hcg, okay, or if the beta hcg value is less than 1000 units, okay, or if the sac size is less than 3.5 centimeter. Okay, these are the criteria for expectant management. Okay, now let's see the criteria for medical management. We have to follow medical management if, okay, the sac size, here also the size of sac less than 3.5 centimeter, but the beta hcg value is less than 5000, okay, and here also no fetal heart sound, and the patient is hemodynamically stable, okay. So here the beta hcg value is slightly higher, more than 1000, okay, somewhere between 1000 and 5000. Then you have to go for medical management instead of the expectant management, okay. And you have to go for surgical management if not fit to both, okay, if not fit to both. So now let's see what are the medical management options and surgical management options. So medical management options. Medical management. The first drug used is nothing but methotrexate. Okay, it is the drug of choice for a unruptured ectopic pregnancy. And other drugs used are prostaglandins, also mifepristone. You can use mifepristone. Okay, actinomycin. You can use actinomycin, vasopressin. Okay, these are the options. Now a few words about methotrexate. Okay, as it's a drug of choice, methotrexate. Okay, the dose of first dose of methotrexate is 50 mg per meter square, IM. Okay, then after the first dose, do serum beta hcg on day 4 and day 7. Okay, then we interpret the result. If beta hcg falls more than 15% of the initial value, then monitoring is enough. Monitoring of the beta hcg value is enough. But if beta hcg fall is less than 10% only, okay, beta hcg is falling but the fall is less than 10% only, then give one more dose of methotrexate. Okay, this is the medical management options. Now what are the surgical management options? Surgical management, it includes salpingectomy, that is the removal of fallopian tube, okay, salpingectomy. Then salpingotomy, okay, then salpingostomy, okay. These are the surgical management options for ectopic pregnancy. Okay, thank you for listening, and if you are interested in medical videos related to emergency medicine, kindly subscribe my channel. Okay, thank you.